Okay, let's begin. Welcome to our surgical viva simulation. Today, we're tackling a classic scenario for the consultant general surgery exams, the thyroid nodule. I'll be your examiner, I'll present the case, and you, the candidate, will walk me through your complete management plan. Let's get started. All right, candidate, let's get into your next case. You have a 45-year-old female in your clinic. She was referred by her GP for this neck mass that she first noticed about 3 months ago. So we'll start at the beginning. A good initial assessment is absolutely key. I want you to talk me through how you'd structure your initial approach, starting with the history and your differential diagnosis. So how would you begin? Just take a moment, structure your thoughts, and then walk me through the key questions you'd ask this patient. Of course, I'd start with a really systematic history. First, I need to understand the lump itself. When did it start? How long has it been there? Has it been growing? Next, I'd want to know about her thyroid function. So I'll screen for symptoms of hypothyroidism, things like weight gain, feeling tired, can't stand the cold. And on the flip side, I'll ask about hyperthyroidism, weight loss, heart racing, feeling hot and anxious. But what's really crucial are the red flag symptoms. I'm talking about compression. Is she having trouble swallowing or any shortness of breath? And invasion, any hoarseness or changes to her voice. That's a huge warning sign for nerve involvement. Then I'd move on to risk factors for cancer, specifically any radiation to the head and neck as a child. And what about family history? Not just thyroid cancer, but related syndromes like MEN2. And finally, I just cover my bases with constitutional symptoms, like fever and night sweats, to keep lymphoma on the radar. Excellent. That's a very thorough and systematic approach. So just based on what you know so far, a neck mass, what are your top differential diagnoses? Right. For a midline neck mass in a woman this age, the list is pretty broad, but I definitely prioritize it. By far the most common thing is going to be a benign thyroid nodule or a multinodular goiter. But the most important diagnosis, the one we absolutely cannot miss, is thyroid cancer. Then you've got other thyroid issues, like a toxic or hot nodule that's causing hyperthyroidism. I'd also consider developmental things, like a thyroglossal cyst. And then you have to think outside the thyroid itself. Could this be enlarged lymph nodes, maybe a parathyroid adenoma, or much less likely, a metastatic nodule from another cancer, or even something rare like a carotid body tumor, though that's usually more to the side of the neck. Good, you've got a solid list of possibilities. So let's move on. You've taken a comprehensive history. Now it's time to actually examine the patient. Let's talk about the physical exam. So walk me through it. Describe the key findings you'd be looking for on physical examination. I want to hear your system from the general look of the patient all the way to specific maneuvers. Okay, so my examination follows that classic hands, eyes, neck approach. I'd start with her hands, looking for a fine tremor, and checking her pulse for tachycardia or bradycardia. Then I'd move to her eyes to look for any signs of Graves' disease, lid lag or bulging eyes. Now for the neck itself, first just inspection. Is there a visible mass? Then I'll have her sip some water and swallow. If it's thyroid tissue, it should move up. I'd also check for Pemberton sign, just in case there's a big goiter extending down into the chest. But the most critical part is palpation. I'll do this from behind the patient, which helps relax the neck muscles. I'll feel the nodule for its size, its consistency, is it hard as a rock or cystic, and is it fixed to the surrounding tissues? A hard fixed mass is obviously very concerning. And to finish, I would carefully and meticulously feel for any enlarged lymph nodes in all the different levels of the neck. There's one really neat trick during the neck exam. If you're thinking about a thyroglossal cyst, you ask the patient to stick their tongue out. If that mass moves up with the tongue, that's your diagnosis. It confirms that connection all the way up to the base of the tongue. It's a simple but really definitive clinical sign. Very good. That's a solid clinical approach. Now we need to get some data to back up your findings. Let's move into the investigation phase. Okay, so you've examined her. You confirm a 3-centimeter, firm, non-tender nodule in the right lobe of her thyroid. You don't feel any concerning lymph nodes. What is the single most important first investigation you're going to order? The first and most important test, without a doubt, is a serum TSH level. That one blood test is the critical fork in the road for this entire workup. So everything really hinges on this TSH result. If the TSH is low or suppressed, it suggests the nodule is hot. It's turning out thyroid hormone on its own. In that case, your next test is a nuclear medicine scan to confirm it. And the good news is, these hot nodules are almost never cancerous. But if the TSH is normal or high, we call the nodule cold, and that carries a higher risk of being a cancer. And for that patient, the very next step is a neck ultrasound. Correct. So the patient's TSH comes back right in the normal range. As you said, your next step is a neck ultrasound. What exactly are you looking for? The ultrasound is so much more than just a picture. It's how we stratify the risk. I'm looking for a specific set of suspicious features. Is the nodule solid and dark, or what we call hypoechoic? That's more concerning. Are the margins irregular or fuzzy? Are there tiny little specks of calcium, what we call microcalcifications? That's a big red flag for papillary cancer. Even the shape matters. A nodule that's taller than it is wide is a high-risk feature. And finally, I'm looking for any sign that it's breaking out of the thyroid capsule or if there are any suspicious-looking lymph nodes nearby.
Right. The ultrasound report comes back. It describes exactly what you were looking for, a 3-centimeter solid hypoechoic nodule. And it has microcalcifications. These are high-risk features. So what's the definitive diagnostic test you need to do now?
With those high-risk features on the ultrasound, the next step has to be a fine needle aspiration, or FNA, to get some cells for the pathologist. Ideally, this should be done under ultrasound guidance to make sure we're sampling the right spot. And the results of that FNA are reported using the Bethesda system, which is just absolutely essential for figuring out what to do next. Let's run through it. Category 1 is non-diagnostic. You just didn't get enough cells, so you have to repeat it. Category 2 is benign, which is great news. We can just follow up clinically. Categories V and 6 are basically a green light for surgery. They're either suspicious or definitively malignant. The real challenge comes with the indeterminate categories. Category 3, or AUS-FLUS, is this gray zone. You might repeat the FNA or even do molecular testing on the sample. And then there's Category 4, follicular neoplasm. This is a classic exam question. The reason it's tricky is because you can't tell a benign follicular adenoma from a follicular cancer just by looking at the cells. You need to see if it's invading the capsule or blood vessels. And to do that, you have to take it out, which means a diagnostic lobectomy is the next step. That's a perfect summary of a very high-yield topic. Okay, let's move on to the final plan. You've done the workup, and now you have your diagnosis. The FNA result comes back. It's Bethesda V6, malignant, consistent with papillary thyroid carcinoma. You've sat down with the patient and delivered the news. Now we're at the critical decision point. How do you decide on the extent of surgery for this patient with a 3-centimeter papillary thyroid cancer? The decision here is all about risk stratification, and we follow established guidelines, like those from the American Thyroid Association. It's mostly based on tumor size. So for a big tumor, over 4 centimeters, a total thyroidectomy is pretty standard. For those tiny little microcarcinomas under 1 centimeter, you might even consider active surveillance instead of surgery. Now, our patient is in that middle ground, between 1 and 4 centimeters. For this group, you could technically consider either a thyroid lobectomy or a total thyroidectomy. It really becomes a detailed conversation with the patient about the pros and cons of each. So, applying the guidelines to this specific patient is key. Yes, her tumor is 3 centimeters, which puts her in that intermediate group. But, and this is the crucial part, she has those high-risk features on her ultrasound, the microcalcifications. That really pushes the recommendation toward a total thyroidectomy. This gives us the best oncologic control and makes it easier to use radioactive iodine later if we need it, and to monitor her with thyroglobulin blood tests. Of course, before surgery, I discussed her in our multidisciplinary team meeting, get a baseline check of her vocal cords, and counsel her extensively on the big risks: injury to the recurrent laryngeal nerve, which could make her hoarse, and permanent hypoparathyroidism, which would mean lifelong calcium supplements. Then, in the OR, the whole game is about meticulous dissection, finding and protecting those nerves in all 4 parathyroid glands. Good, that's a well-reasoned surgical plan, thinking about everything from pre-op to intra-op. The surgery goes well. Now let's talk about the long-term outlook. Well, the overall prognosis for her is excellent. For differentiated thyroid cancer, especially papillary, survival rates are very high. We can formalize her prognosis using scoring systems like AGES, which looks at age, grade, extent, and size. At 45, with a 3-centimeter tumor that's confined to the thyroid, she's definitely in a low-risk group. Post-operatively, she'll need to be on lifelong levothyroxine. This isn't just to replace the hormone, but also to suppress her TSH, which can act like a fertilizer for any remaining cancer cells. We'd watch her calcium levels very closely right after the surgery, and her long-term follow-up would involve regular checkups, monitoring her thyroglobulin levels as a tumor marker, and periodic neck ultrasounds. Very well done. You've navigated this case perfectly, from the initial presentation all the way to long-term planning. I'll leave you with one final question to think about. What if that FNA result wasn't Bethesda 6? What if it had come back as Bethesda 4, follicular neoplasm? How would your initial surgical plan have been different, and why?